My name is Binu Varghese, and I'm one of the gastroenterologists in Rotherham Hospital. Today, I'm going to talk about acidic drain insertion for teaching purposes. So first of all, we have to make sure what the indication of the drain insertion. So it's usually to relieve the symptoms. Patients who have got decompensated liver cirrhosis, they end up with massive ascites. And when it is compromising with their breathing, or if they are in discomfort, then we put the drain in. So the contraindications to acidic drain are you have to check the INR first. So the INR should be less than 2. Next is if patient is pregnant, or if they have any organomegaly or any obstruction or ileus. Distant bladder is also a contraindication, and if there is any additions to that. So before proceeding for the procedure, make sure you have taken the consent from the patient. It's a consent form 1 if they're able to do consent for the procedure. So first we have to scan the patient and find the appropriate place where we are going to insert the drain. Then we need the dressing trolley and the sharp spin. Make sure it is near to your dressing trolley. We need a sterile field, which is here, and you need your sterile gloves, and make sure you have draped yourself as well. We need chlorhexidine swabs to clean the area, and then we need a 10 ml syringe, a blunt needle, that is to withdraw the lignocaine. That lignocaine is usually 10 ml that you use 1% or 2%, and which we insert into the skin. Next, you need the green needle, the blue needle, and the orange needle. So the orange needle is to anesthetize the skin. Then we go a bit deeper with the blue one, and then the green to go further down. So you got the scalpel. We've got the rocket multipurpose needle drain, which has got holes at the tip, and then it is curved initially. So if you see, it comes like this. So you have to straighten this with this red tube. It goes all the way up to the tip, and then you insert the needle all the way through so that it comes out of here. Sometimes it becomes a bit difficult because it's plastic. And then you screw at this end and make it tight, and it's ready. Don't take this out and don't throw it away. So that's ready. This is the drain that attaches to the bottom of here. It's a 3-way. It has got a 2-way tap. So it connects there. Make sure that it is locked. Otherwise, you might drown yourself with the acidic drain that comes out. 2 latex-free dressings, like the Tegaderm. And then we have got the blue drape that has to cover once you have sterilized the area. And then this is to cover that. And then you've got the scissors and a catheter bag. And for the final dressing, it's an leave-in dressing that has to go on to attach this drain. So next is to scan the area where you're going to go. Normally with decompensated chronic liver disease, you see that the liver is shrunken because it's cirrhotic, and then the spleen has enlarged. So I try to do it on the right side because you're sure that there is not going to be any organs. Left side, make sure that when you mark the area, that there is no spleen interfering there. Okay, so Patrick is going to be a bit cold.
Yeah.
Yeah, so he's got plenty of fluids. I'm going to go for the lower space. So I can see plenty of fluids on here, and there is some bowel loops that I can see. So the black area that you're seeing on the scan is where the fluid is. So I'm going to mark that area. So we're going to spray this area with some chlorhexidine, making sure that it is all sterile before we start the procedure. Also, make sure that the area is completely dry. Next, I'm going to cover this area and make it completely sterile. So Patrick, I'm just going to cover it around. Don't bring your hands over this.
Do what?
And also with another blue sheet, make sure you cover underneath as well, so you've got a sterile area. Thank you. Yeah, you don't have to move. And we have some lignocaine next. We're going to take some lignocaine. That's 1 or 2% lignocaine. I'm going to take 10 mL. So this is 1%. Just check the dates. They're in date. Yep, great, thank you. No, that's fine. This stays better, isn't it? So next we are going to use the orange needle, and I'm going to anesthetize the skin. Make sure that you go with an angle of around 15 to 30 degrees to the skin. Avoid any blood vessels on the surface of the skin, and try to make a bleb. Sharp scratch.
Yeah.
Always aspirate to see that you're not in a blood vessel, and then try to create that bleb. Rotate it around. Give some more. So I'm going to give around 2 to 3 mils there. Okay. Keep the sharps onto one side so it doesn't interfere with your space. Next, I'm going to use the blue needle. Go perpendicular to the skin. Sharp again.
Oh.
Sorry. Aspirate and inject a bit. Okay, withdraw. And keep the blue needle again onto the side. Next is your green needle. Right.
Painful, that.
Another sharp. So I'm already getting the flash of the ascites here. So withdraw a bit and then inject your lignocaine there. So you're actually anesthetizing the parietal peritoneum. We'll wait for another 2-3 minutes until he's completely anesthetized to that area. Next is take the scalpel and protrude it so that it's around like 1 to 1.5 centimeters, and go perpendicular to where you injected. So can you feel it now?
No.
No.
I can that.
Is it like a sharp or a
Oh,
pressure?
yeah,
Okay. So I just made us. Okay. So next we'll take the rocket multipurpose needle and also take the drain and keep that here on your sterile area. Then I'm going to make sure that the bevel is up. I'm going to introduce it straight, perpendicular to the skin, and insert it as soon as you feel the give-in. Like I've got the give-in. Undo the screw at the bottom and keep the needle there, and slowly introduce this catheter into the peritoneal cavity. So this catheter is going there. Make sure that you don't take the needle out at all, otherwise it will kink. So I've introduced it completely. I can see the ascitic fluid coming out already. I'll take the needle out now and close that end and put this catheter onto there. As I said to you earlier, it is locked so that I am not flooded with ascitic fluid. Then I connect onto the catheter bag. And put it onto the side of the bed, and I'll open the drain now. So I can see all the ascitic fluid coming out. Now I have to make sure that I fix this drain onto the skin. So first of all, can I ask Diane to come over here to hold it for me, please? So I've got the leave-in dressing. So how we do the dressing here is, this has been formulated by Diane, who is our sister on theatre treatment suites, which is a very good one. So we just make a cut across halfway through, take the dressing from the back, and the cut goes from the bottom. So we just go across and cover it. So that's all done. And remove the bottom bit as well. And then we stick 2 tegaderms on either sides, so they are remaining perpendicular to the skin. So the drain is fixed now. And I'll remove all the dressings now for him. So the procedure is complete. Next, we want to make sure that for every 2.5 liters to 3 liters of acetic fluid that is drained, we give 100 ml of 20% albumin and give it over 15 to 30 minutes. Make sure that for every 3 liters, you give 1 bottle. For every, if the patient becomes hypertensive, make sure that you just close the two-way catheter and this way, so it's not draining, and then make sure you give some albumin. I'm going to leave it open for now. And the drain remains there for 6 hours maximum, and make sure you have taken the drain out of after 6 hours. You can take some samples if it is done for the first time. Make sure that you send the acetic fluid for cell count, albumin to do your serum albumin acetic gradient, also for culture sensitivity and gram stain. Make sure once you've done the procedure, dispose of all the sharps, so your needle, your scalpel blades, your scissors, and all your green needles, and the blunt needle as well. And dispose of all the other bits into the clinical waste.